Thank you, Felipe, for these kind and wonderful words. Uh, our friendship goes back to almost 20 years. And in fact, by showing this picture, it shows members of our team visiting Professor Valdivia at the Clinica Alemania in 2018. But in reality, as you heard from prior comments, our friendship goes back to almost 20 years. But I mainly want to recognize Professor Valdivia for his leadership. At the time when we got together, he approached me 20 years ago. There was no organized effort in Chile to address the problem of neuro-oncology, and certainly no multidisciplinary approach. And he is to be credited for having developed, helped find, recruit his collaborators on the oncology side, on the radiation side, on the imaging side, to put together this multidisciplinary team. And I'm certainly glad to see that we are continuing our collaborations with the help of Dr. Lang and Dr. Pudavalli. I also want to recognize Constanza, his wife, because every great person is backed up by a great partner. Constanza has been a wonderful partner. She has opened her house for us when we visited Santiago, and here in this picture taken in Houston a couple years ago for a symposium that we were happy to have them join us at. So thank you, Felipe and Constanza, for your hospitality and your friendship. Now, whenever we talk about surgery for malignant gliomas, and of course, glioblastoma being the standard of that, we shouldn't forget that this was, for a long time, a very controversial topic. This critical summary that I published about 20 years ago highlighted the reasons for the controversy. Some of it was, of course, due to lack of imaging. We didn't know how much tumor was removed. The surgeon cannot predict really without the help of imaging. Many patients had incomplete resections, not because they're a bad surgeon, it just didn't have the tool, or it wasn't in the culture, it wasn't the standard that one does complete resection. Complication was high, and so on and so forth. Histology was not as advanced as what Dr. Fuller described to us today with all the molecular advances. And the statistical tools that they used to analyze the series were flawed, they were deficient. And so when you mix all of this together, you end up with a huge controversy, wondering whether more surgery for a glioblastoma is going to help the patient live any longer. Now, let's not forget, we can never do a prospective randomized trial. It's just not ethical. I cannot tell a patient, I'm not going to remove your tumor because the computer puts you in the category where I have to do less than a complete resection. It's just never going to happen. So the best we could do was take these controversial points and address them in a prospective manner, as we did in this study published in 2001. Michel Lacroix was a fellow with us at the time, and with Dr. Abisaid Suki did this multivariate analysis where we took a large number of patients, all glioblastoma, and we specifically measured the extent of resection using volumetric techniques that I will mention in a minute, and correlating that with survival. So by doing this, we have addressed or tried to address all the controversial points that I had mentioned in the previous slide. And so here's an example of a patient who had a large glioblastoma, resected, and the terminology that was used, like I'm showing on the right here, is this subtotal resection? Is this near total resection? Is this gross total resection? All of these terms have been used to describe this particular patient. So it tells you that terminology is really the wrong way to go. And the best way to go is to do volumetric computerized analysis. We did that at a time when there were very few softwares available. Here, Wei Ming Shi was one of our full-time employees, who was a Chinese neurosurgeon who helped us do this volumetric measurement through scanning and then measuring a volume. So now we talk about volume. We don't talk about partial resection or subtotal resection. And this is what our data showed, is that as you increase the percent resection from below 85 to all the way to 100% resection of the contrast enhancing mass, you see that the median survival and the rate ratio and the p-value all steadily increase. The p-value became significant when we crossed the 89% volumetric resection with a p-value of 0.04, but that p-value went up to a very high significant number, and the median survival of 13 months when we reached 98% volumetric resection. And that's why our paper emphasized the 98% resection to maximize the benefit of surgery. And here, in fact, is where you see the separation of median survival. It is significant at 50%, but as you go further down the curve, you see the separation becomes more evident, and the long-term survivors, which in this case was about 15% of the patient alive at 5 years, occurred only when we did in practically 100% resection of the enhancing tumor. Now, what this slide shows also is what we all know, the biology of a glioblastoma, especially as Dr. Fuller described, the IDH wild-type glioblastoma versus the astrocytoma grade 4 with mutant IDH. These patients here, no matter what you do, are dying quickly. No matter what great surgery is being performed, these patients are dying. So again, the emphasis is we need more research, we need more understanding of what drives these tumors, better therapies than what our standard is today. But despite the limitations of today's biology, we can, and from our standpoint, from a surgical standpoint, we can impact the survival of a significant number of patients, and I will show you more data on this. So we classified patients according to certain criteria. I want to point out Group B, where if you, Group B are younger than 65 with a Karnofsky score of 80 or more. So these are in good shape patients, and they're very common patients that we see. There's about 90 patients in this particular slide. And you could see that if you do 98+% resection, you have here a 30% 5-year survival. Remember, this is glioblastoma. So it is not anecdotal. This is not an occasional patient. There are a significant number of patients. Of course, the younger and the better performing patients, the more likely it is that one would want to be very aggressive. This is data I have not published that shows you the patients who live over 5 years. We call them long-term survivors, are shown in yellow. They all practically had 100% resection of the enhancing mass. So to really demonstrate how important it is that we do such complete resection is to see the number of patients we're able to help through that way. And yes, there are molecular factors, MGMT methylation, IDH mutation. All these will impact survival, but even in those who have a wild type IDH, complete resection will make them live longer. Now, I was pleased to see 10 years our paper that Dr. Mitch Berger from UCSF duplicated our results. In their case, they showed that a minimum of 78% volumetric resection is required. In our paper, it was 89%, pretty close. But I emphasize that even in their paper, they say that if you do 100% resection, you will have better survival than less than 100%. So again, even though you may not be able to do 100%, if you can do 100% resection, you are likely to help more patients with the resection. Then a couple of years later, one of our fellows, Nick Marco, who has background in mathematics and mathematical modeling, used our data. And unlike our 2001 paper, he only chose patients in our database that followed the Stoop protocol. In our paper in 2001, there was no Stoop protocol. Telomozolamide or Temodar was not yet invented or has not entered the standard of practice. So what Nick did, he showed that you can personalize for each patient prior to surgery from your own computer. You can enter age, KPS, and then plot the extent of resection and see that yellow line that you in fact are increasing survival steadily from low percent resection all the way up to 100% resection. Of course, an older patient like here, 84 years of age, will benefit less, will still benefit, but will benefit less than a young patient age 40 and KPS 100. So you can, as I said, personalize for each patient before you operate on them and determine what is the likely benefit if I go from a 70% volumetric resection to 95% volumetric resection. This paper was published in Journal of Clinical Oncology, which is a highly competitive cancer journal in the United States, and so it was very well received. However, when I tried to have Nick look at what happens if we do over 100% resection, well, by the time he was gone, and so next fellow, Michael Lee, then did the study, which is the title of my talk, is Can We Do Better Than Gross Total Resection? In this series, we had over 1,200 patients that had complete resections. The hypothesis is that if 100% resection of the enhancing GBM mass lead to improved survival over lesser resection volumes, could additional resections of the surrounding non-enhancing flare signal provide further gains in survival? And to support that are the data on patients who recur after surgery, and 75 to 80% of the patient will recur within 2 centimeters of the resection wall. So there is something around the wall of resection that is more relevant to residual tumors. And Charlie Wilson, back in 1994, showed graphically that beyond the main mass, which is mostly tumor and necrosis, you have this zone, which is approximately 2 cm, where there is the highest concentration of infiltrating tumor cells. Of course, we know that tumors can infiltrate way beyond, including in the other hemisphere, but really most of the money, most of the interest and the relevance is in this zone, which is immediately around the tumor. That is why when we did our study, we looked at what happens immediately outside of this enhancing mass. Here's a right frontal tumor, ugly, necrotic, obvious GBM. And here's on the flare, you could see this zone, 2 centimeters plus or minus, that is immediately around where infiltrating tumor cells are expected to exist. Now, here's a little more critical location, dominant hemisphere. near the speech center of this glioblastoma. But then here again, you could see this 2 plus or minus centimeter of flare abnormality surrounding the tumor. So this is a very common, as we all know, finding. And the question is, can we go after that area of infiltration? And so in our study, we of course confirmed that 100% resection of the enhancing mass leads to better survival than lesser than 100%. But the innovation of this study was that we looked at the volume of flare tissue that is around the tumor before the resection and after the resection. And here you could see that 20% of the patient had actually more flare tissue after resection than before. And that is presumably due to surgical trauma, edema, inflammation, or whatever, vascular injury. But 80% of the patient had increasing amount of resection of the flare volume, including this 27% patient who had 50% or more resection of the flare volume. So that for us was an indication that we have gone beyond the margin of resection to try and quantify how much that is. And here you could see, I highlighted in yellow, on the left is the percent flare volume resection from 50% volume up to 100% volume, number of patients, and median survival. And you could tell that the median survival is 20 plus months once you exceed that threshold. Now, this is not statistical because we had to correct for age, Karnofsky, and other things, but it just gives you an idea how it impacts the survival when you do go beyond the edge of the enhancing mass. And so here's this example I showed you where we did the resection. Here's the contrast, here's the flare, and you could see that we were not wild and crazy in approaching this case. Nothing we removed here, particularly this medial aspect of frontal lobe, was resected, can be done safely without hurting the patient. We did not go after the insula because that would be crazy in this situation. So we have removed not only the whole mass, which we must do, but we have removed significant amount of surrounding flare that we hope will help this patient. Now, in a more critical location, this patient that I showed you before, although it is in a dominant temporal lobe, we did the patient awake. We mapped that the speech center and tract are all around the tumor. And so we were able to do a complete resection, not only of the enhancing mass, as we show in the bottom left, but also of all the flare abnormality around it, as shown in the bottom right. And so, and the way we do it is we, after we map, we define where the edge of the lesion is. We do a corticectomy, and we do this en bloc, or what we call peri-lesional resection. So this way we assure that we got the whole tumor out. And in fact, we published this last year with one of our fellows, showing that you get superior results, lesser complication when you do this type of peri-lesional resection. Of course, that demands mapping so that you know you're not entering any functional brain. And when we did multivariate analysis for these patients, you could see, as predicted, on multivariate analysis, correcting for age and Karnofsky, the median survival of patients who previously were not treated, newly diagnosed, with over 50% volumetric resection of the flare abnormality, you get a median survival of 23 months compared to 18 or 11 months for the other categories. So there's no question that doing this type of resection is likely to lead to more better control and better, longer survival. Lastly, the 25 National Cancer Institute designated centers, cancer centers in the United States, have a database where they publish results on all cancers in neuro-oncology. In this particular case, the craniotomy numbers for MD Anderson is the highest for that particular year, as you could see here, compared to all the others. And the mortality is comparably low. So what this tells us is that despite the aggressive approach we have taken to go after glioblastoma and resecting the tumor and beyond, we are not hurting the patient. There's other data on lengths of stay and complication that equally show low numbers for our patients. So in closing, we really have to look at this patient and say that this woman, 55 years of age, presented with headache and hemiparesis, had a craniotomy. You could see the craniotomy here and there. The surgeon went in, removed the necrotic part of the tumor, and left all this aggressive part. Look at the midline shift. Look at all the surrounding edema and tumor infiltration. And so this patient had a full craniotomy with no benefit, zero benefit. We don't need this kind of surgery to make a diagnosis. We know what it is. So what I had, unfortunately, to operate on her because our radiation therapist would not treat her. She is a high risk for radiation therapy with this kind of shift of the midline. So she had to have a definitive operation where I had to go in and clean out the entire tumor, and she was home in 3 days. So we can do that without hurting the patient and hoping to help the patient. In closing, maximal safe resection of the contrast enhancing tumor result in significant survival advantage. Additional resection of surrounding flare abnormalities seems to confer a significant added survival advantage, but we should never forget that the surgeon and the treating team must use their judgment. Judicious selection of patients, careful analysis of imaging, employment of state-of-the-art surgical tools and techniques are all determinant factors favoring an improved outcome. Thank you again, Felipe and the team, for inviting me to share those thoughts with you.